So first of all, huge thank you to RSB for inviting me and to Phil for setting this up and hosting it. I'll start by introducing myself. So I'm Hannah Baker. I'm a health economist at Mtech Access. And I've been working in health economic consultancy for 5 to 6 years now. And I'm based up in York for those who are interested. It's quite a technical, sometimes behind the scenes job that I do. So I do like to take these opportunities to come out into the open and demystify things a little bit for those who are interested. So I was really excited to be asked to give this webinar this evening. I hope you all learn something new about how healthcare decisions are made in the UK. And as Phil pointed out to me yesterday, once this lecture is up on YouTube, I'll be able to direct my friends and family to it next time they ask me what it is that I do. So that's a bonus as well. Anyway, let's get into it. I expect my presentation will last for probably around 40 to 45 minutes, so we can have a bit of Q&A at the end. So first of all, I referred to myself as a health economist, but in fact, the type of health economics that I do in my day-to-day job is just a small part, really, of the overall discipline. And I would love to say that I'm an expert in the whole field, but I'm going to stick to what I know, which is economic evaluation at the treatment level. So that will be the focus of this lecture. I'm biased, but I think it's a good place to start. So as biologists, or perhaps just people who are interested in biology, you'll probably all be familiar with the drug development process. And you'll be aware that for a new treatment to be approved for use, it must be proven to be safe and effective. And specifically, it generally should be proven to be at least as effective as the treatments that are already on the market for that indication. So those criteria alone might rule out perhaps 90% of newly developed or newly discovered drugs, but not all safe, effective medicines will be approved for use in the NHS. We have to be a bit more picky if we want to optimise healthcare. So you might be wondering, to begin with, what is economic evaluation? Well, it typically involves assessing the costs and effects of a health intervention compared to the relevant alternatives. And health economists, such as myself, conduct economic evaluations of healthcare interventions. So that might be new drugs, prevention programs, or possibly medical devices. And why is it necessary? Well, economic evaluation is there to combat this challenge that we're continuously facing in the UK. And in fact, it's by no means necessary, so no means unique to the UK. There are many other countries who have adopted economic evaluation out of necessity because their health systems would not work efficiently without it. So the NHS, as we all know very well, doesn't have access to an unlimited pot of money. So that's what we would call a resource-constrained system. Yet demand for healthcare continues to grow. In fact, you could say that demand for healthcare is infinite. We have infinite wants when it comes to health. You could blame that on an aging population, on growing burden of chronic diseases, all sorts of other factors. But whatever's causing that, those two were battling. Essentially, we've got this limited budget, we've got infinite healthcare wants, and as a result, there are decisions or choices to be made. So let's consider one such choice. So if you had a personal healthcare budget, and if you were to choose just one of these three healthcare interventions to be made available to you and your family, you'd want to be fairly convinced that it's the one that is going to provide maximum benefits within your budget, or at least that's what a rational consumer would do according to economic theory. And when we make a choice like this one, we should be informed about the what we would call the opportunity cost of that choice. So what is the value of the foregone alternative? You know, we could have spent that money on something else. What value would we have derived from that something else? And with other types of choices, we as consumers are well placed to make those decisions for ourselves because we can value the alternatives ourselves. So, for instance, in deciding what to have for dinner, what to make for dinner, you might weigh up maybe the time taken to prepare that meal, the nutrition that you would get from each of them, the cost of the ingredients, and most importantly, the overall enjoyment that you would get from that meal. And the value that you place on each of those factors might vary day to day. Some days you might want something a bit more comforting. Other days you'd be happy with a salad. But you with a quick mental calculation, you would be able to make your choice. And I hope at this point that I haven't lost half the audience who have gone to have a look in their fridge to see what they're having for dinner. But my point is that it's not so easy with health, because first of all, we have a national health system, and so decisions about the availability of medicines and other healthcare are made at a national level. So this already takes it out of the hands of the general public. But even if you were responsible for making those decisions at an individual level, such as choosing between these three healthcare interventions, most of us, if we're being honest, we're not sufficiently informed to make those decisions. There are lots of unknowns in healthcare, which makes it a bit of a kind of awkward market to study in economics. We don't know when we're likely to need healthcare, and we don't know which treatments are most appropriate. So whilst other types of goods and services might be left to the market, where supply and demand meet at a point of equilibrium, we just can't do that with healthcare. Purchasing and prioritization decisions need to be made, and they need to be made robustly and using kind of explicit criteria. So that's why economic evaluation is needed. I'll transition a little bit into how we do it. And in practice, we don't consider a batch of new healthcare interventions like the three examples on the previous slide, and decide which of the three of them is going to be approved. Instead, new drugs or devices will typically be assessed one at a time. So let's consider a hypothetical drug A, and costs associated with this drug, with drug A, could go far beyond the cost of the drug itself. We're also interested in associated resource use within the health system, or costs of managing the disease, treating the side effects of the disease, side effects of the treatment, and so on. And there are some other types of costs not mentioned here that might be considered as well. So I'll come back to those later on. On the other side of the scale, health benefits are usually quantified in terms of length of life, years of life gained, and quality of life. And I'll come back to those later on as well. So I said that new interventions are typically assessed one at a time, but in order to assess the value of introducing drug A, we do need to compare it against current practice, or standard care. So let's say standard care is drug B, and this is a fundamental pillar of economic evaluation, that you're drawing a relevant comparison. What it means in practice is that drugs indicated for use in disease areas where a host of expensive treatments are already available will be compared against those expensive drugs. Or drugs entering a market full of generics will be compared against those relatively cheap drugs, and vice versa with health benefits. So it will, if a drug is entering an innovative market, the benchmark is a bit higher. Essentially, it will need to demonstrate benefit at least as high as those other innovative treatments that have already been approved. Drawing a relevant comparison means that we can derive the incremental cost of drug A and the incremental benefit of drug A, and the incremental just being a fancy word for the difference. And with those two things, the incremental cost and the incremental benefit, we have the ingredients for a cost effectiveness analysis. So over the next few slides, I just want to be explicit about what's meant by costs and health benefits. So we'll start with costs. Direct costs refer to the costs of health services, such as cost of drugs, staff time, providing a bed for a patient in hospital, the ambulance call-outs. Essentially, any costs which are incurred directly by the health system or the healthcare provider. Indirect costs refer to the costs of productivity or personal loss as a result of the disease, or perhaps as a result of undergoing treatment. So the patient might need to arrange their own transport into the hospital to attend an appointment or whatever it may be. They would typically all come under indirect costs. And then it's the perspective of the evaluation, which can be considered kind of one of the key settings of an evaluation, which determines whether indirect costs should be included or not, whether they're relevant. And they're generally not included within UK evaluations, but in many other countries they are included. Costs are familiar, so I won't linger anymore on those, but I'm going to start to introduce some new terminology, or terminology that may be new to some of you, starting with utilities. So at a very basic level, a utility is a measure of health-related quality of life. They can take any value between 0 and 1, where 0 represents death and 1 represents perfect health. In actual fact, it is possible to have a negative utility, that this would represent a state of health which is considered worse than death, and thankfully in practice that is quite rare. So I've described the crux of what a utility represents, but it's also important to understand how they're derived, because utilities help us to value different states of health, which in turn is what allows us to make decisions about healthcare. And you might remember one of the objectives of the webinar, or something that was mentioned in the blurb, was to tell you how societal preferences are accounted for in economic evaluation. Because we're not just, and I hope you'll agree with this by the end of my talk, we're not just crunching numbers in the background with no regard for what people actually value when it comes to health. Population preferences are built into our health valuing system. Sorry, I'll go back to that slide. So it starts with a questionnaire being developed. So I'm going to work my way through the infographic here from top to bottom. Starts with a questionnaire being developed, and I'll show you an example of one of those in a moment. The questionnaire will output essentially descriptions of health states. So in the second step, those health states are described to a sample of the general population, and then via specialist methods that we won't go into now, the population sample values those health states. And with that information, an algorithm can be generated. So I'm on to the third step now. And those first three steps, they don't need to be repeated every time we want to do an economic evaluation. They're only necessary really when a new instrument for measuring health-related quality of life is in development, or perhaps an existing one might be revalued. They might keep the same questionnaire, but ask a different population to value those health states. The final two steps describe the practical implementation. So this is the bit that needs to be repeated, I suppose, for each disease area. The questionnaire is given to patients, perhaps in a clinical trial, to collect real data on their quality of life, maybe before, during, and after treatment. And we then use the algorithm to turn those questionnaire responses into a utility value. So I appreciate that's quite a lot of technical information, so I'll use an example to breathe a bit more life into that. So the example I'm going to talk you through is the EQ5D, and that's the most commonly used questionnaire for measuring health-related quality of life. So it's represented by this circular infographic here. The 5 domains are mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. And then each of those domains is rated on a scale of 1 to 3, with 1 representing no problems in that area and 3 representing severe problems. So you can see that in the kind of excerpt of the questionnaire in the middle of the slide. Now you might think that these 5 domains can't possibly tell the full picture of someone's health. And in some instances, you might be right. There are other disease-specific instruments which are, in some cases, more appropriate for certain diseases. But for the sake of consistency, this generic instrument, the EQ5D questionnaire, is used in the vast majority of evaluations in the UK. And actually, from those just from those 5 domains and the 3 levels of response for each of them, there are 243 possible health states. And one of those health states is the example at the bottom of the slide, in the box on the left. So perhaps we've conducted a trial and one patient has reported a health state of 31111. So that means that they have severe difficulty with their mobility, but no problems in the other domains. We can then apply the established mapping algorithm for the EQ5D, which is actually quite a straightforward process. There are online tools that will do this for you. And in doing that, we've condensed that sequence of 5 numbers into a single value. And that's our utility, the 0.336. So this one was mapped according to UK population preferences, but you could conduct this same exercise using a different country's preference set, and that would yield slightly different results. You'd get a slightly different utility. In practice, there is going to be a lot of variation between individual patients. If this was a trial result, for instance, even if the patients are all from a similar population with the same disease, they've received the same treatment, they're not necessarily going to share the same health state, and the reasons for that patient level variation are not necessarily going to be relevant to the disease or the treatment of interest. So we would conduct this mapping exercise for all of the EQ5D data that we've gathered in the trial, and then each patient would have a utility value, or perhaps they'd have a utility value for each of the follow-up points of the trial. We would usually then average those patient level results for use in our evaluations. So the next health economic buzzword I'm going to introduce you to is the QALY. QALY stands for Quality Adjusted Life Year, and it's a composite measure of length of life and quality of life. And remember that quality of life is represented by utility. So for instance, 4 years of life spent at a utility of 1, in other words, perfect health, would result in 4 QALYs. 10 years of life spent at a utility of 0.6 would result in 6 QALYs. So quite a straightforward composite measure, but why do we use them? Well, they're an exchangeable currency, and what I mean by that is that they allow comparison across different disease areas where we might otherwise not be able to compare because the clinical outcomes, you wouldn't be comparing apples and apples. We wouldn't typically be in a situation where we're directly comparing a drug for instance, diabetes against a drug for Alzheimer's, say, but we do implicitly need to be able to draw those comparisons and compare the health benefits of all sorts of different interventions across the health system. So using a generic measure like the QALY allows us to do that. I hope you're ready for the next acronym, the ISA. Nothing to do with tax-free savings. It's just another health economics buzzword. ISA stands for Incremental Cost Effectiveness Ratio. We've talked about costs and we've just talked about QALYs. Both of these are estimated in our economic evaluations. So in this example, we've got costs estimated for drug A and drug B, and similar for QALYs. So at this point, we might know that drug A is overall more expensive than drug B. We might also know that drug A is overall more efficacious, or it results in more QALYs than drug B. But those results on their own aren't useful for decision making yet. Perhaps the incremental costs associated with treating a single patient with drug A is £100,000, say. But for that additional cost, we estimate that the patient would gain an additional 6 months of life at full health. So that's half a QALY, half a year at full health. So we have £100,000 on one side of the scale, and we have half a QALY on the other side. So who's to say whether that is value for money? We need to be able to make these decisions, as I said earlier, robustly and explicitly. So we need to apply a decision rule. And the first step towards our explicit decision rule is that we combine the incremental costs and QALYs into a single measure, the ISA, which is simply the incremental costs divided by incremental QALYs. Here's another example where we have, it's still drug A and drug B, but let's say that the total costs associated with drug A are £35,000. Total costs associated with drug B are £15,000. So we have an incremental cost of £20,000, the cost of the differential of drug A versus drug B. Similarly, 25 QALYs for drug A, 23 QALYs for drug B, meaning an incremental of 2 QALYs. And just to put those results in a bit of context, obviously a hypothetical evaluation, these are per patient results over a patient's remaining lifetime. So then our ISA would simply be 20,000 divided by 2, so an ISA of 10,000. And to put that back into context, it means that to introduce drug A into the health system, we would be paying an additional cost of £10,000 per QALY gained. But we still can't say whether it's good value for money. Let's look at this graphically as well. So on this plane, we have incremental costs on the y-axis and incremental QALYs on the x-axis. Each one of these points that I'm going to show you represents an intervention, a new intervention, and specifically we're looking at the incremental results of that intervention. So you can consider there being a comparator which is directly in the center of this graph at the origin. And the red example here is clearly not good value for money because we can see it costs more and yet it provides worse health outcomes compared with the alternative. The green example clearly is good value for money. It costs less whilst providing better health outcomes compared with the alternative. So that's a win-win situation. And the terminology I've got here on the slides, the green intervention would be said to dominate the comparator because, exactly as I said, it's less costly, but provides better outcomes. Interventions which are more costly whilst providing worse outcomes are said to be dominated. So we've got a dominant and a dominated intervention there. So those are fairly uncommon situations. The most common situation is we have interventions up here in the northeast quadrant of the graph. These blue examples aren't quite so clear-cut in terms of decision making at the moment because they both provide better health outcomes compared with their alternatives, which, as I said, can be considered as points at the origin. We're not necessarily comparing these interventions against each other. They both provide better health outcomes compared with their alternatives, but they do also cost more. How can we say whether they're good value for money? And finally, I'm going to tell you how we can say. So I've added to this graph a line to represent the cost effectiveness threshold, which is otherwise known as willingness to pay. There's an established value for this threshold in the UK. It's £20,000 to £30,000 per QALY. And this threshold represents the amount that we're willing to pay as a society for each additional QALY that a new intervention can provide. So on this graph, the interventions falling below the willingness to pay threshold are considered cost effective, whilst the interventions above it are not considered cost effective. And as I mentioned in the again in the blurb for this lecture, rather provocatively maybe, health economic evaluation does involve assigning a monetary value to a year of life. So the cost effectiveness threshold essentially gives us an exchange rate between QALYs and money. So coming back to this example, we had an ISA of £10,000 per QALY gained. And I've just said our established willingness to pay threshold is £20,000 to £30,000. So the ISA is less than the threshold, and therefore drug A would be considered a cost-effective alternative to drug B. And it's as simple as that, really. Of course, I don't want to reduce the work of me and my colleagues down to it's as simple as that. There is a huge amount of research that goes into each one of these economic evaluations before we can get to this point. But the calculation itself, calculating an ISA and then applying that decision rule, is relatively straightforward. It's just getting to this point that can be quite time consuming. So I've harped on about this decision rule, but you might wonder, who's actually making these decisions? It's not me, it's above my pay grade. In fact, there's a governing body called NICE, the National Institute for Health and Care Excellence. NICE was established in 1999 to reduce variation in the availability and quality of NHS treatments and care. They are a key stakeholder in the health economics industry, and ultimately they're the end user of many economic evaluations that are conducted in the UK. They continue to lead the way, not just in the UK, but internationally, with methodological guidance on economic evaluation. But one of the main things that NICE do is to assess new medical treatments in what we call HTAs, health technology assessments. And since they've started doing these in the year 2000, NICE have conducted over 900 assessments of new medical treatments. If you're interested in how they assessed those, you can actually access all of them on the, well, I say all of them, probably not the oldest ones, but particularly the most recent ones. You can access them on their website. So you can review the kind of dossier of evidence that was submitted for each new drug. And if you really want to be a fly on the wall, you can actually register for free to observe upcoming committee meetings. And those committee meetings are where the decisions are made. They discuss the cost effectiveness evidence, the clinical evidence. They hear from patient advocates, clinical experts. They discuss it all, and ultimately they reach a conclusion, not necessarily in one meeting, but over the course of several meetings, they'll reach a conclusion on whether certain drugs should be approved for use on the NHS. Just to set expectations, usually as members of the public, you would be kind of evicted from the meetings by the time they get to this decision-making point. But you do get to sit in on quite a lot of it. So if you've got any particular clinical interests, yeah, perhaps you'd be interested to join one of those. So you might be wondering now at this point, or perhaps you're not, what is my role and the role of my colleagues in this process, if we're not the ones actually making the decisions. So health economic and market access consultancies are commissioned by pharmaceutical and medtech companies to help them with economic evidence generation, amongst other things. And in terms of when this might be needed, it could be on the approach to a NICE submission, which involves submitting a very thorough dossier of cost effectiveness evidence and clinical evidence to be considered by that decision-making committee that I just mentioned. Or we could be commissioned much earlier in the drug development process to provide what we call early cost effectiveness evidence, and that can help inform subsequent evidence generation, pricing strategy, and prioritization of that company's assets. Or we can help companies who have already launched their product with communicating the economic value of said product to their customers. We have a really fantastic digital team who specialize in making really cool digital tools which our clients can use to communicate better with their customers. And if you want to see an example of one of those tools, then check out the Mtech Access website where there's a demo, although do be warned, it contains clip art images of feet. Anyway, Mtech Access is made up of health economists, evidence specialists, medical writers, global market access specialists, and more. And many of the team have got more than 20 years experience in market access. So if this talk has piqued your interest and you want to know more about our services, including bespoke training provision, please do visit our website and get in touch for a conversation. We'd be very happy to speak to you. So I'll pause there on this slide where you should be able to see a QR code. If you follow that QR code, it will take you directly to our company LinkedIn page. So if you want to connect with us, see what we're up to, what services we can offer, then yes, please do that.